No, we'll move on. We are running about 25 minutes late, but we're moving on now to Katalin Furedy, who's going to give us a talk about her and her partner, Karesz, from Hungary. Katalin lives in Hungary and worked previously in international studies, financial institution security, and fraud prevention, a high-paced, stressful work environment. Her life partner for 23 years, Karesz, suffered a brainstem stroke on the 18th of April 2025, resulting in locked-in syndrome. For Katalin and Karesz, their relationship meant love, stability, safety, support, warmth, happiness, and balance. They lived together 24/7 and for the past 5 years worked on their air conditioning repair business. By choice, they had no children. Katalin was by Karesz's side in hospital every day for 7 months, arranging the best available therapy and care for him until his untimely premature death. Close relatives and friends provide great emotional support during her ongoing painful grieving process. Katalin, I'll now hand over to you to give us your presentation. Thank you.
Hello, everyone. I'm very happy to be here and for the opportunity to present our story. Unfortunately, it is only me since Karesz has passed end of last year. So this is my first Zoom meeting, so I will try to, as Shannon has mentioned to me, you have almost no knowledge of how the healthcare system and the treatment of LiS patients work in Central Europe or in Hungary or even in Eastern Europe. As a context, I would like to tell you that so the Hungarian and Eastern European healthcare system is famously known for being in a terrible shape. So that's why I wanted to let you know how things work around our area. And we can move on to the next slide, please. Thank you. So this is just the agenda I will be going through. We can skip this. Thank you. So it's a timeline that is more graphic and clear way that you can see what happened during these 7 months when Karesz got into the hospital. And so first week the brainstem stroke happened and there were 2 diagnoses. And then he was in intensive care for quite a short time. And then we got stuck because of the newness of this, and the Hungarian health professionals are very unfamiliar with locked-in syndrome. That's why we got stuck in neurology, because there was no other available option at that moment. And after a very long fight and many efforts made, it was a very short time spent in a rehabilitation center. And when everyone gave up on his improvement, then a final decline and his death happened. So next slide, please. Thank you. So my main reasons is, of course, providing information about how the healthcare system is handling locked-in system patients, even with all the limited resources we have at the moment. And I'm telling his story, everyone, as a memorial and also a cautionary tale, which I will get to later, and also collecting knowledge on LiS patients all over the world and the newest available therapies and accessible tools for improving their quality of life, and understanding their struggles, as we never got to a point where we could home care Karesz, and he had to stay at the hospital. I would like to also connect more with the community and maybe giving advice if it's something that I have lived through or experienced, and suggesting areas of improvement, especially with communication for vertical eye movement. Next slide, thank you. So in Hungary, we have the last name first. So Tóth Károly, my partner, he was born in 1974, December 21st, and he died aged 51, so still quite young. And for brainstem stroke, he suffered it quite late in his life, as it's usually happened to under 40s. And he was an IT engineer, system administrator, and certified AC technician. And you could see from his hobbies and from his personal qualities, he was a very strong, great man who loved sports, loved the outdoors, and he was a great support in my life and the love of my life. So yes, next slide, please. Thank you. So as I mentioned, the night before the stroke is something that I always tell as a cautionary tale and explain people the atypical symptoms, because just recently I was in a first aid education, and they told us all the typical symptoms, and none of the ones I have here, Karesz symptoms, were mentioned as an indication for stroke. So I think this is something that needs to be said more and spread, because people are not realizing how grave the situation is until it's too late. So he had cold sweat and he was trembling, but very lightly, a slight dizziness and imbalance, difficulty of walking straight, but still being able to walk around. He had some flickering lights in his peripheral vision when the night lamp was on, and he could still eat, but also had a quite difficulty swallowing. But there was no unilateral weakness in limbs or drooping face or slurring of speech. We tested all the known symptoms for stroke and closed that out. So next slide, please. Thank you. So in the morning, Karesz woke me up at 8 and said that he's feeling worse, so we should go to the hospital. But his condition deteriorated quite fast, so I had to call an ambulance. And when we arrived in the ER, he was tested for stroke, and then they did a CT scan, and it is documented that they didn't find any obstruction in the blood vessels. So he was to be remained in the hospital just for safety, and he could come home within 2 or 3 days. And while they were filling out the paperwork, in 30 minutes, alarming indications of a brainstem stroke appeared. And even the doctors and nurses ran around frantically, and they had to call an angiologist who did an emergency thrombectomy through his thighs. But unfortunately, during the operation, his blood vessel wall burst, and that's why he had to have a stent inserted. And as far as I know, he had to be reanimated at least 4 times during this operation. Next slide, please. Thank you. So the first few days in the ICU, we just called it a living nightmare, not just for him, but for all the relatives and friends. Even though in this unit, everyone was extremely friendly and very helpful. And so for the first 3 days, he would closed eyes. His medically induced coma lasted 2 days, and then they said we have to wait at least 1 more day to rule out brain death. But even then, he had 0 response to outside stimuli, and there were some involuntary movements and reflexes. And because of that, of these indications, the doctor sat with us and said that that is inevitable. He is brain dead, and there is a 0 chance of survival. So we have to think about ending the life support, and I persisted that we should wait more. Even though I never heard of this minimal conscious or LiS diagnosis before, I said that we should at least give 2 weeks to see if there is any improvement. And on day 4, they tested him with my voice recordings, which I left for him to the night with poems and fairy tales. So he showed minimal signs of consciousness with vertical eye movement, and he was still on full life support system with cables hanging all around him. I could hardly access him in his bed. And he had a pressure control ventilation, a tracheotomy, nasogastric tube catheter. And when I left and asked him if he would like to listen to music through the radio, he had a strong upward eye movement of yes, even though that was not established as a mode of communication. Next slide. Thank you. So they did, after 9 days, they did a control MRI, which showed a complete necrocytosis of the brainstem and a small area also above. And they said that the chance of the slightest recovery is around 1%. Then they established the communication of yes/no questions with vertical eye movements. So we established his basic physical needs. Although at this point he wasn't completely in understanding of what happened to him, and it seemed to us that he was in a kind of a haze, sometimes dozing off for days and coming back and being more active. He had profound sweating on his forehead and perceived constant heat. It was always warm, even in the springtime. He had pain in his lower extremities, and slightly in the first few weeks, micro movements appeared, which gave us some hope, like his head tilting right and left, his big toe wiggled, and then gradually all his toes wiggled a little bit on both of his feet. Some movement in the face appeared, so we could be more perceptive of if he was in pain or happy to see us. And we had to explain to him that the feeling of hunger and the sensation of starvation will continue because of his feeding tube. He won't be able to eat food in a normal way anymore. And his sense of touch remained and even heightened, as well as for hearing and smell. He was very so we couldn't put on headphones. We tried to put on headphones so he could listen to music or movies all day long without annoying the nurses or other patients, but he couldn't stand it, so this failed. Next slide, please. Thank you. So regarding his emotional state, normally in Hungary, they allow relatives to visit a patient for 1 hour a day, but I managed to be by his side 3 to 4 hours every day. But this took a lot of paperwork and pleading, and he was really happy that we were staying by his side, talking to him to ease fear. And of course, at first, he was very happy that he survived, but also as his conscience became more clear, he also expressed that he didn't want to live in this state. And he was very in distress when visiting time was over, the final one, and I had to leave him there in the ICU. And there were slight shakes and trembling throughout his body. There was a cognitive assessment made on week 2, at the end of week 2, and he answered every question correctly. He was perfectly oriented in space and time, aware of his situation and the gravity of his state. And we tried to establish communication. The first one was I was reading the alphabet out loud. This was inspired by a movie. And then he had to look up when I got the right letter, but it was also difficult because of the delayed reaction from him. And when his vertical eye gaze improved, we made some alphabet boards similar to this one on the slide. Next slide, please. Thank you. So there were more improvements, not just micro movements appearing, but he went off the ventilator successfully, and he got intensive physiotherapy care, and this was but all passive workout and exercises. In the weekends, it was me who did the physiotherapy, and once a weekday, the therapist and me in the afternoon. So we tried positioning, but because of the tracheotomy tube and the buildup fluids in the lungs, turning was very difficult, and he had to be suctioned off immediately once turning to one side. They tried aromatherapy breathing exercises and strengthening eye and face muscles. I tried the muscles for Bell's palsy, if maybe it improves the movements in the face. And he started blinking in the left eye. Screen time was still off limits. He was very sad about that, but his spasm threshold in case of epilepsy or another stroke, it was forbidden for him to look at screens. And it was the maintenance of all his life support systems was amazing in the ICU. And that's where they first mentioned that we had to get a PEG insertion, which is normally after 6 weeks if a patient cannot eat normally. But he had a lockjaw, and so a gentle incision-free operation was off the table, and he wasn't strong enough. And as you can see, the PEG is normally just a feeding tube through the stomach. So then he was put to the neurology progressive care unit, and it was just for about a week. And this is where they completely terminated his ventilation with support. And he just had respiratory oxygen given from 15 liters per minute to 8 liters per minute. And there were some new therapists as well, a physiotherapist with 30 plus years experience. And she wanted to make his lower extremities move more. And she started carefully adjusting his body to a seated position. But it was a very tedious and long-term goal to get him seated in a seated position, treating the orthostatic hypotension. And she did really everything to repair his distal motor functions or just get some back. And the speech therapist, we were really lucky because she was one of the best professionals in the country with profound understanding of LiS and asphyxia. And she treated similar patients in the past with success. She tried to improve his eye gaze, even horizontally, strengthening his face muscles, giving massages, growing his attention span. And she brought in a Tobii Divanox eye tracker to the hospital. And a nurse who worked there for 20 years, she said this is the first time she has seen this device. So they really, really tried everything to help him. And that's where we got stuck on the neurology ward, because at that time they deemed him not to be fit for rehabilitation. It was absolutely off the table. So, and other departments or wards or hospitals wouldn't take him. And the TMS therapy. So I talked with the director of this ward, and we agreed that the TMS therapy is excluded because of the stent inserted in his brain. And I got a permission to obtain an electrotherapy equipment for neuromuscular electric stimulation to at least maintain his remaining muscles. And I read this in an article, an interview with Tracy Gibbs, and even showed him this interview.
Mm-hmm.
But then the leading expert of rehabilitation said that, so all I understood that he said, because the pyramid signals are missing in Karesz's brain, these electric impulses would do more harm than good. And I listened to his expertise, and so I didn't got this device in the end. And Karesz's horizontal eye movements unfortunately never returned. So the adaptation of Tobii or any other high-tech communication device was based on horizontal eye movements. So we couldn't go further in improving his communication and the quality of communication. And as I mentioned earlier, the request for rehabilitation was multiple times denied, and it was absolutely off the table because they said, especially in this trembling and crumbling Hungarian healthcare system, it would be an enormous work with very little reward. And I started enrolling him into BCA trials, but unfortunately he was not eligible and didn't meet the requirements. Next slide, thank you. So the only viable communication we could come up with, so his Karesz's up-down fixed gaze was fully clear. We had to enhance the middle gaze, so like looking at the horizon at one point was difficult for him, and staring at fixed points for a longer time. We used context-based boards with three-part division, which was inspired by UCAPO. And so it was like, do you need a pillow? And if he said yes, then I put a pillow. There was a picture of a pillow under his head, under his trunk, or under his legs. And so that's how he could decide, or he could tell us where he wants a pillow placed under him. And then E-Tran board was the cornerstone of our communication and him connecting with the world. I manually hovered a board in front of him because he couldn't gaze horizontally. So we had a three-part division, but vertically, and I moved this table in front of him. And we had to get it homemade because in Hungary, also this device was unheard of, and I was unable to purchase one. So everything here mentioned was almost everything homemade. And he could sit at the edge of the bed a few times with assistance of 3 physiotherapists whilst wearing a neck brace. And I requested a psychologist to estimate his mental state and maybe provide some emotional support. But they said that there is not, that they couldn't have such an expert who could get through the communication barriers to evaluate his condition. Thank you. So this is like an E-Tran board. So something similar I have made myself to help better communication. And in the best times, when he was the strongest, he could spell out at least 10 sentences in an hour. So we were very proficient with this device. And then there was a first deterioration after the peg surgery. There were multiple negative outcomes. He already was battling infections, and he got some additional, which caused the higher dosage and broader spectrum of antibiotics being used. He had terrible constant abdominal pain for at least a week and had to be put on high dosage of painkillers. He had a very low oxygen saturation of around 70 to 80%. Although support was halted for 2 months, so he had to be put back on the ventilation machine. And it was reintroduced at maximum level. And if for 3 days, this was on a weekend and a Monday, he had no response to outside stimuli. So all the relatives, friends came in to say goodbye. And unfortunately, after this, he never recovered to his previous stable state where he could have been rehabilitated. And after 5 months and 2 weeks, and lots of fight from Karl's side, because he was supported by almost everyone from the therapists and doctors, because they saw his willing to fight and get better. And on the other side, my fight with the healthcare system and the accepting institutions. He was finally accepted at the most renowned, well-equipped institution for brain damage at the early stages of coma. This was in our central capital in Budapest. And well, all the treatment he got there was he developed a single pressure ulcer under his heels that were expertly handled and healed. But any other effort was put aside, and the expert opinion on the final documentation was that he's not even fully conscious. They labeled him an entity, unfit for rehabilitation, and was excluded from every effort towards recovery. So when this institution puts a label like that on someone, it means that every door in the country closes. And also because of his multiple infections and the strain of the transport to the capital city, which took about 2 hours, and the new environment resulted in pneumonia. And they said that they are not prepared for management of medical emergencies such as this, and they lack the knowledge of equipment to take responsibility for his survival in their institution. So he was re-referred to the previous neurology ward, where every therapy discontinued. As I said, this closed every door in front of us. And then after 2 weeks, or like maybe 8 days, he was referred to our small city's hospital's chronic disease ward, dubbed lay-in. That's the nicest word I can say for it. Every patient who gets in here, they're basically, everyone has to be prepared that they will die in the end process. Next slide, thank you. So in this ward, although still visiting him every day, and in this ward, the maximum time for visiting was 20 minutes per day for one relative, which meant one relative could go in 20 minutes and the next day another relative for 20 minutes. And of course, I said, given his state and also doctors mentioning that we have to be prepared for the worst, I managed to get 3 hours of visiting time each day. But even with so much assistance and help and being there, I could see the poor maintenance of his life support systems. They were absolutely not prepared to manage someone's systems within this severe condition. There were no tracheostomy tubes. I had to buy them, and catheter as well. So they had no equipment. I had to provide everything, so at least they get changed a couple of times. The bandages were never replaced. Suctioning was irregular, and saturation levels were never checked. I had to bring in this meter so they can check it. Despite the repeated antibiotic treatments, which happened every week or twice a week, his high fever returned every 2-3 days, increasing every time. And they explained to me that the unilateral fever is indicating an abnormality in the hypothalamus that cannot be repaired or reversed with any kind of medical help or assistance. We just have to accept that his fever will get higher and eventually defeat his body. And the overuse of antibiotics caused starvation because his gut couldn't process all the nutrients that got in through the PEG. And in the end, his radical weight loss, septic shock that was visible, and extremely low saturation levels caused his death in 2025. Next slide, please. Thank you. So we had very limited communication, but his thoughts and feelings throughout this journey have been expressing wishes of getting home, being seen and included. He asked me multiple times not to be ignored, not just by us, but the medical professionals, his fear of death, and that we should be taking his complaints seriously. He was repeatedly asking for medicine, suctioning, mouth cleaning, catheter change. Every time we really took his wishes seriously, because twice they put in the catheter wrong, and it caused heavy cramps, and he was visibly suffering. Well, for us, after seeing him for so long time in this state, we knew, even without movement. And we really tried everything to lower his body temperature, especially during the summer. We got anti-decompressing pillows for every body part. And every week I requested up-to-date information and consultation from doctors and nurses about his current condition, treatments, therapy, and future plans. Because in Hungary, they usually discuss this with the relatives outside in the corridor. And I had to ask them to please always come to the bed and let us discuss this in front of Karesz. And because of his mental state, he also had irrational thoughts. Like he told me this many times that a specific nurse who was very rude, she gave him poisoning, which caused his paralysis. And then he would multiply ask for dissection, that in case of this death, we should look for traces of this poisoning. Or he was missing non-existing objects and worrying over the hospital bill and finances. On the positive side, especially in the ICU and when he was in a better and stable state, he suggested playing games like 20 questions, catch, or tic-tac-toe. And we had lighthearted conversation with friends, expressing that we would meet next summer for festivals and hiking. It was his idea to introduce the Morse code and use it as a method of communication. But his blinking was so inconsequent that it was really hard on him to accept that we cannot use this code. And he was given very little screen time between my visits, and he expressed that he wanted to look at WandaVision. So that's what he was looking at. And so there was also a little bit of light at the end of the tunnel and a glimmer of hope, with kind and caring nurses washing and shaving him and preparing me to take care of him if ever he got home and needed 24/7 assistance. The speech therapist, she was dropping by every spare time she had to check in on him, especially in the mornings when I couldn't visit him. And the physiotherapist relentlessly trained Karesz every day for these 5 months and 2 weeks while he was in the neurology ward, for very little improvement, but she didn't give up. And the hospital director was checking in, following his journey with attention, and he also helped in organizing his rehabilitation. And fellow patients and their relatives gave us also huge emotional and physical support with uplifting words, help packing his things and carrying supplies, because almost everyone in this neurology ward was in a much better shape than him, because as the leader of the rehabilitation center said, he came across a handful of patients diagnosed with LiS in his 20-year career. So they just, I sensed a lack of knowledge and huge gaps on where to put a patient with LiS and how to treat him. And friends organized fundraiser, especially to acquire a Toby once he got home, and offering financial help for these specialized equipments for wheelchair. We tried out this MyWare 2.0, which is a muscle sensor to operate machines, such as simple as raising an alarm if he needed something and nobody was watching. And his buddies were visiting every week, so he felt being loved and not forgotten. Thank you very much, everyone.
Oh, Katalin, what a very moving story. Thank you very much for making the time to explain the terrible hurdles that you faced. We're all, our hearts go out to you. There's lots of hearts appearing on the screen. We're all deeply concerned about that treatment. What do you think can be done about the Hungarian system? Is there any practical?
I had very little experience before with the Hungarian healthcare system, and by stories which I heard and news on the television, I was expecting much worse. So I would say if someone has the means, especially financially, and support from family and connections, they can get the best care and efforts from centers. But especially if someone is older, alone, doesn't have the financial means, I would say they wouldn't last more than a couple of weeks locked in. So that's why they said that, well, the leader of the rehabilitation center and ward said that throughout his career, well, maybe he saw 2 handful, like 10 patients, and maybe 5 made it to the wheelchair. But everyone said that Karesz has made 7 months through this, in this condition in Hungary, is like a miracle. Because most of the people are being either disconnected from life support system within a couple of few days without even realizing that they're conscious.
They don't even try.
Or don't even try, or most of them, because of lack of care and support, they die within a month.
We have some questions coming through. Fernando, would you like to ask a question?
Stefan was first.
Sorry, you came up first on my list. Stefan.
Okay.
Yeah, I'm interested in how you use the MyAware. I tried to use MyAware in my device, and I found there were issues with the placement of the electrode sensors, and also there were some more fundamental issues. How did you use MyAware, and how did you get the sensors attached to, and where did you attach the sensors?
So thank you. Very, very good question. Maybe I didn't mention that all of these were just experimentals from our side. So we really didn't know exactly what we were doing. I have a friend in intensive care, a doctor, and he recommended that we should try this muscle sensor. And because he has the knowledge, he came in to look at cause involuntary and slight voluntary micromovements in the limbs and in the pecs. So he did the placement, but unfortunately, as you mentioned, this MyAware isn't sensitive enough to pick on. So you need to have a much stronger muscle movement or spasm for it to pick up the signal. And we couldn't get very far, but we tried it at least 3 times with the different placements and different muscle groups. If there is anything strong enough to give a signal to a connected device, but it didn't work, unfortunately.
Yeah, I agree. It's a great system. It looks like it'd be wonderful if you could get the accuracy of it working, but I eventually had to give it up too.
Yeah. Thank you, Stefan. Thank you for your question. Fernando, would you?
Just thank you, Katalin, for your testimony, which is it's very important. And I think one of the reasons why it's important, this connects to Shannon's question, is because across the world, improvement in situation for persons affected with complicated conditions such as the locked-in syndrome improve only with the pressure of patients. It is always, in every country, it has always been a bottom-up movement, a grassroots agitation and commitment, so to speak, that has led to improvements in the situations. I just wanted to mention, so it is very important that, people like you, you're not a patient, but you're obviously from the family or affected persons like Howard and others, um, to somehow try to give testimony and press for an improvement of situations. And the most recent success story that I know about this is the so-called ALS law that was passed in Spain in 2024. It's known as ALS law because it was really driven by persons affected with amyotrophic lateral sclerosis and their families and associations. But fortunately, it's not restricted to ALS. It also concerns persons affected with locked-in syndrome who will now, with the new law, be able to benefit some much higher support from the public health system. The second hurdle, of course, is the application of the law. This is a different matter, but the first step is to get the law passed and the public health measures taken. And I just want to underline how important it is for people like you and from people who are affected to to move. And I mean, Shannon, of course, knows this very well because she's done that largely in Australia. So it was just a commentary and to thank you once again.
Thank you.
Thank you, Fernando. Thank you again, Katalin. It was really good to have you with us today. Thank you for sharing that your story. We're sorry you've gone through such a devastating experience.
Thank you very much for your attention and taking time to hear our story.
Thank you, Katalin.